Good morning to everyone. On behalf of the Florida Department of Health in Volusia County, welcome to the 2021 Path for Hope Virtual Summit. My name is Lynn Kennedy and I will be your facilitator for this session. You have joined the session titled Harm Reduction is Health Promotion. All participants will be muted during this session and your cameras are off. We are inviting questions throughout the session, either in the chat or by raising your hand. And if you scroll to the bottom of your screen, you should see an option to raise your hand. And we'll try to recognize you as the questions arise. Let's see, you may also submit, as I said, through the chat question, and we'll recognize those as well. We want to thank our Path for Hope Summit Planning Committee partners, Advent Health, Community Coalition Alliance, One Voice for Volusia, SMA Healthcare, and the Volusia Recovery Alliance. I would like to offer you a brief biography of our guest presenter today, Laura Viafora Ray. And she is a dedicated public health professional who's been working in the fields of health promotion, public health, and health sciences for a decade. She has worked on a variety of public health programs, youth safety, HIV prevention, HPV vaccine promotion, healthcare access, and mental health, but has become exceedingly passionate in her current role working to decrease opioid overdose deaths in Jacksonville. She believes everyone, including people who use drugs, has the right to live, thrive, and seek health and wellness on their terms. Welcome, Laura Viafora Ray.
Thank you so much, Lynn. Good morning, everyone. My name is Laura Viafora Ray, and I'm very pleased to be talking to you this morning. I have presented a lot about the work that I've done in Jacksonville over the past couple of years, which firmly can fall under the harm reduction umbrella. But I'm also fortunate today to maybe have the opportunity to even dive deeper than just what we're doing in practical terms and in terms of the data, and also sort of encourage anyone on this call who's not sure about harm reduction or who maybe doesn't have a full understanding of what it is or what it can be. Because as you can see from my title, I don't believe that harm reduction work should be separated. I believe it should be incorporated at all levels of prevention work, and that it truly is health promotion for a lot of our target populations that we work with in this field. And just a little bit about what brings me here today to speak with you about this topic. I'm currently the project director for the Safe and Healthy Neighborhoods project with the Jacksonville Fire and Rescue Department. We were fortunate enough to receive an FR-CARA grant under SAMHSA, which started a couple of years ago, and I've been directing that project ever since. The main goals of that project are to distribute Narcan, which can temporarily reverse an opioid overdose, educate individuals on how to use Narcan, and increase their confidence that they could properly administer it to reverse an overdose and save a life, refer people to treatment and recovery services and other appropriate resources, and for everything that we do with this project to be as data-driven as possible, both collecting and analyzing our own data, sharing that data with partners, and also receiving data updates from our partners to get as clear of a picture of what's going on with overdoses and how to prevent them in our community. I'm also a visiting instructor with the University of North Florida, the Brooks College of Health Department of Public Health, and I'm also the faculty advisor for the UNF chapter of Students for Sensible Drug Policy. So anyone with a background in public health is probably familiar with these levels of prevention, but just in case you're not, basically there's 3 levels of prevention: primary, secondary, and tertiary. And what I've come to realize, or maybe I've already known it, but now I just really want to communicate this idea to others so that you can look at things differently, is that harm reduction, once again, should not be treated as something separate from these levels of prevention. And it also doesn't need to be allocated to just one. It really can exist at all levels. So primary prevention is typically defined as preventing the negative outcome of interest or of concern from ever occurring to begin with. Secondary is detecting those negative outcomes early on in the process. And tertiary is effectively mitigating and minimizing the harms that could be associated with that outcome of interest or outcome of concern. And I use the term outcome as opposed to something like disease or illness, because of course in public health, outcomes can be a variety of things, including disability, injury, as well as of course diseases and illnesses and behaviors. So where does harm reduction fit in? As I mentioned, I believe harm reduction can fit in at every level. All you have to do is redefine how you look at a negative outcome. Redefining it not to just simply see it as substance use or misuse that you're trying to prevent, but rather other types of possible outcomes associated with substance use or misuse. So it can be a primary prevention strategy if you're talking about the outcome of interest being HIV infection, Hep C infection, endocarditis, which is an infection of the heart that can occur when someone reuses a syringe, for example, if they inject drugs. It could be preventing overdose, injury, and death. We also can redefine our target population beyond just those who have never used or misused a substance and not ignore those that are already using substances. Harm reduction is health promotion, and it can be primary prevention specifically for this population. Looking at secondary prevention, it has a role in this level or layer of prevention as well. We can use harm reduction strategy to detect a negative outcome or an outcome of interest early on in the process. So for example, one of the things that we might want to detect early on would be at-risk substance use. So many individuals use substances, but we want to identify those factors, those signs that someone may be using substances in a risky way. And so a way that we can do that using sort of harm reduction principles and strategies is to ensure that we're providing people of all ages, yes, including youth and adolescents, with a safe and judgment-free environment to discuss drug use. If individuals feel like they have to keep their drug use a secret, which is often the case, especially with youth, adolescents, maybe college students, then you miss that opportunity to detect early on if substance use has gone past just experimentation or just casual recreational use to more problematic use. HIV screening is a perfect example, especially in relation to a common harm reduction strategy, which is providing individuals who inject drugs with a clean syringe in exchange, or rather a sterile syringe in exchange for a syringe that's been used. So we can use these programs to detect HIV early on in the process by encouraging participants to get tested and to get tested frequently. The earlier you detect HIV and get someone connected to treatment, the better the outcome will be for that individual, as well as any of their potential sexual partners or individuals who they may have been sharing syringes with had they not have had access to a syringe exchange program. Hep C screening is similar. You can detect it early on so the person get connected to treatment as soon as possible and also prevent them from possibly spreading it to others. Wound care is another example. If it's managed early on, a wound from injection drug use can be appropriately mitigated or managed so that the person never has to go in the hospital for a serious infection. You can prevent the infection by detecting the issue early on by having providers work in syringe exchange programs that can look at individuals' wounds before they get to that point of hospitalization. And keep in mind that for some of these individuals, these are the only points of service where they are even going to get connected to the secondary prevention strategies, because perhaps they've been so stigmatized in other healthcare settings that harm reduction programs are truly the only programs where they feel comfortable and they are able to get connected to these types of services. And of course, there's tertiary prevention. We can't prevent every outcome from occurring, but we can mitigate and minimize some of the harms. So where harm reduction plays into this, providing low barrier access to medication-assisted treatment, preventing a recurrence of use for those who have chosen to abstain from select substances, and not creating unnecessary barriers for them to things like housing, employment, getting custody back of their children. Having support groups that are welcoming of everyone on all types of recovery journeys, including those who use medication-assisted treatment, who may not feel comfortable or may not feel welcome in all types of support groups. Again, harm reduction strategies can really help to mitigate and minimize some of the effects by preventing someone from experiencing a recurrence of use by making these types of things more accessible. Another one, going back to a syringe exchange program, will be connecting individuals to HIV and hepatitis C treatment once it has been detected. I mentioned with secondary prevention how it's always best to detect these things as early on in the process as possible, because that will equal a better prognosis, essentially. But also, it's just important in general to get them connected to treatment once it's been diagnosed. And going back to wound care, if someone, again, is not receiving any kind of medical attention related to their injection drug use, and they have wounds related to that could turn into infections, it's also important not just to maybe prevent hospitalization, but also to encourage someone to, to have a provider say at the syringe exchange program, hey, we really need to refer you to a higher level of care because it has gotten past the point where we can effectively treat it here in this setting. And you can, you can't force someone to go to the hospital, but you can encourage them in that place, using compassion, using kindness, and you've hopefully developed that rapport with them to encourage them to actually get the care that they need. So I just, in general, don't know if this is still the case. I've seen paradigm shifts in real time just in the last couple of years, but I think that for a long time, harm reduction was treated as separate or even sometimes antagonistic to prevention strategies or to recovery-oriented strategies. And I've seen preventionists and harm reductionists work really effectively side by side, and I want to continue to see that. I've seen harm reductionists and people who work in the recovery field work side by side, and I really want to see more of that because I've seen the successes that we can see with that type of partnership. Because these strategies can fit together and work together to create multiple layers of a safety net so that no individual slips through the cracks or feels stigmatized at any stage in the prevention process. And I also encourage everyone to really rethink prevention messaging at all levels to prevent further harm. An example of this, I follow a lot of Reddit pages. For those of you who aren't familiar, it's a type of social media. It's much older than some of the ones that we typically think about, like Facebook or Instagram. It was around much longer than that. It's a much more basic format than those types of profiles. And there is more of a level of anonymity to the use of Reddit compared to other social media profiles. And the benefits of this for me, always trying to understand these processes and understand the perspectives of individuals who use drugs, inject drugs, et cetera, is that, they're maybe more open on these types of forums. So I read them a lot, try to gain an understanding, try to see what I might be missing. Is there implicit bias that I'm accidentally, propagating? And one example, and this is particularly relevant right now because we're about to enter Red Ribbon Week, is I was reading a post about Red Ribbon Week, and it was a mother who was posting and saying, anybody who works in prevention or treatment or, especially in the school setting, please be very mindful of what types of messaging your school is promoting during Red Ribbon Week. And the reason is she said that her daughter was so, traumatized by the messaging because her father was currently in inpatient care for substance use disorder. And, the messaging that she said that her daughter was receiving at school was drugs are for losers, drugs are for people who are stupid, things like that. And this poor girl was just so traumatized by all this messaging that, she felt was directed to her family that she didn't even want to go to school. So I say all of this just, again, to really encourage rethinking messaging, to recognize, use some of the harm reduction strategies that are tried and true, meeting people where they're at, including children who have families who are experiencing these things in real time. Approach everything with kindness and compassion. And I'm not saying that every Red Ribbon Week uses that type of messaging, but if you notice that a school is promoting that type of messaging, please be courageous and stand up and say, hey, is this really the message that we want to be sending? Of course, we want to, recognize that we want to prevent, children from engaging in substance use, but we also need to realize it's a reality that a lot of children, at the very least, have family members that are experiencing this right now. And that's going to become more common over the years because of the spikes that we have seen in overdoses and in substance use, particularly in the midst of the pandemic. And another story I'll briefly share, that's related to that is that my mother-in-law is a 5th grade teacher. At the beginning of this school year, she was informed that one of her students had just lost their mother to an overdose, not but less than a week prior to the beginning of the school year. And again, this is going to become more and more common, and maybe we're just talking about it more and it's always been present, but we just want to be really familiar because so much of the prevention conversation happens in schools. We also don't want to forget that there are children whose families are dealing with this in real time, and we want to be sensitive to that and compassionate to that. I also encourage you to really think about the word stigma. I have noticed, it's become such an important conversation and such an important dialogue, but I don't want it to get lost in the milieu of these conversations and just become another buzzword. And I fear that that's what's already happening in the world of talking about preventing substance use, et cetera. And I'm not just talking about language. Of course, language is important, but what I'm referring to is a little bit more nuanced than just, person first language, although that is very important. I'm talking about how we talk about stigma, we talk about combating it, but there always seems to be a qualifier, or there often seems to be a qualifier. So if we're ignoring one group, if we're not combating stigma with every group, with every type of drug use, with every type of substance use, with every type of mental health challenge, then we're not really combating stigma. So I kind of refer to it as like the everything but. I've heard this come up a lot, but I've heard it, in the course of my work. But rather than share one of those examples, I will share an example from pop culture. So there's a TV show on HBO called Girls, and you don't need to know much about it except for that one of the characters talks very openly about her drug use. She's kind of one of those no-nonsense characters that is very open about her life and doesn't, take anything from anyone. But I do really remember a particular scene where she was referring to her heroin use, and she said something to the effect of, oh yes, I, did heroin, I loved heroin, but I only snorted, I never injected. And the character says it in a way, it's sort of a sense of pride for her that she never used that route of administration, that she never injected the substance, she only snorted it or used other routes of administration. And, I do think that life imitates art and art imitates life. So that always stuck out to me, that scene, as, it was interesting that she kind of wanted to qualify. Oh yeah, I'm very open about my drug use, but I really want to make sure that everybody knows that I never injected, as if it was sort of a point of pride almost. And I really, again, hope that in real life and in the course of the work that we're doing, that we're not, including those kinds of qualifiers either. And, I'll talk more about, our exploration of having a syringe exchange program open here in Duval County. And, this is something that I've brought up. I've said, if you truly are wanting to combat stigma, then you can't say that and then say, well, I support this measure and this measure and this policy, but then draw the line on anything that would help someone who injects drugs. Oh, that's where you cross the line. I really just think that if that's where you're coming from, you might want to start to rethink that, because at that point, you're not really combating stigma, you're putting a qualifier there that shouldn't be there. And another example is, we talk more and more now about protecting marginalized groups from stigma, particularly. So individuals who inject drugs, individuals who are homeless or otherwise marginalized, etc. And a really poignant example came up for me recently to illustrate this concept as well. I'm also a part of a neighborhood social media group in the neighborhood that I live in. And I promise I do more in my life than just go on social media, but it can be a helpful tool. And someone in the neighborhood was posting about how there was a pile of like, what seemed to be trash outside of a local abandoned business. And they were ranting and raving about how they were sick of, trash just being everywhere in the neighborhood and how he was going to do something about it. And someone, commented, interjected, and they said, hey, this isn't trash. This is a homeless man's belongings. Unfortunately, he was taken to the hospital recently by ambulance and he was forced to abandon his possessions. So please don't throw away his stuff. I'm going to come and organize it and leave him a note to make sure that he knows how to get his stuff whenever, he is out of the hospital or what have you. And everyone chimed in and said that that was such a wonderful thing that this Good Samaritan was willing to do that. But then even with all those positive comments, some negative comments came up about how regardless, people shouldn't be trashing the neighborhood, and, why don't you just go to a homeless shelter, and, oh, the person probably got carted off to in the ambulance because they had overdosed on drugs because they're homeless. And the Good Samaritan, who had said that she was going to collect this individual's things for him and leave a note and all of that, she commented on every single post, and it was a really long thread. And she said, oh, I've gone through all of his stuff and to organize it for him and all of that. And there was no drug paraphernalia, there was no drugs, and she commented on, every single nasty comment like that. And I couldn't help but think, why don't we take it a step further? What difference would it make if this individual did have drugs on them or drug paraphernalia, if that was the reason that they had to go to the hospital? This is still a human being. This is still a human being who almost lost all of his possessions because he had no choice. He had nowhere to put it. He had nowhere to store it safely when he experienced a medical emergency. And this person who did a good deed objectively still kind of didn't take it far enough in terms of defending this person's life by qualifying it and saying, well, he's worthy of this kindness because none of his stuff had drugs or drug paraphernalia. And again, I just thought that that was kind of a nuanced example of what I think about a lot in the course of my work, and how I just hope that, everybody experiences implicit bias, but I just hope that people really think, am I combating stigma, or am I still inserting a little bit of implicit bias where I need to expand my worldview, expand my perspective, and approach this with as much kindness as possible. So now that I've hopefully kind of set the stage on some of the paradigm shifting, hopefully, thoughts that I've been having over the last few years, I also did want to share, in practical terms, what we're doing with the Safe and Healthy Neighborhoods Project and the Narcan Distribution, and also some of our efforts with getting a legal syringe program open in Duval County. So just a little bit about who we've partnered with so far with Narcan Distribution. We have given out well over 5,000 kits since we began in September 2019. We've partnered with a number of treatment centers that are all listed there. These treatment centers are very diverse in the sense that they range in terms of size. Thankfully, in terms of location, they're all located in what we would consider to be some high-need zip codes in Jacksonville, those zip codes where there are higher rates and higher numbers of opioid overdoses in particular. I did want to point out, Gateway is one of the largest treatment centers that we partner with, and that represents easily 6 departments, maybe more. It's kind of hard to keep track, that are distributing Narcan. And also, I think really critically, they have a satellite office of their outpatient program in one of the homeless shelters in Jacksonville, and they're distributing Narcan out of that satellite program as well, which I think is really a critical population to be reaching. In addition, all of these treatment centers, their staff have had the opportunity to be trained in Narcan, to receive their own kits to carry on their persons at all times or whenever they feel appropriate. And new staff that are onboarded always have the opportunity to reach out to us to get training if they can't receive it, from somebody else who already received the training. We also have a number of community-based partners that are also very diverse. I've had the fortune of partnering with a small ministry called All Signs Pointing Up. And it's the type of organization that at first glance wouldn't seem like the type of organization that would be open to Narcan distribution, but they really are, and they really are encouraging similar types of ministries to embrace, harm reduction strategies like Narcan distribution, and really encouraging them, to see that Narcan distribution is not enabling, it's just something that can save someone's life if they're in a life-threatening situation. So they do outreach at some of the hotels where we know a lot of overdoses occur. And it's just been so critical to give them Narcan to do some of that really direct outreach. We've partnered with organizations that particularly serve, some intersectional populations. So Jasmine, for example, is a nonprofit that serves LGBTQI plus youth and adolescents. And so, one of the things I wanted to make sure was, since that population can also sometimes experience stigma in different healthcare settings, I wanted to make sure that there was at least one place, if not more, where someone in the LGBTQ plus community could know that they could get Narcan in a place where, it would be safe and judgment-free. Inspire to Rise is a nonprofit that does a number of services, and critically, they're located in the highest need zip code on the west side of town, where we do see the highest number and rate of overdoses in the city. And then two other partners I did want to briefly touch on, because I think that they're sort of fall into the realm of unique or non-traditional partners for this type of work, but it's been really, really helpful and life-saving in many cases. And that's been our partnership with private security companies, as well as a security academy that actually trains security guards. So if anyone's not familiar, in order to be a type of security guard in the state of Florida, you do require certain licensures. And there's also, additional continuing education for people who want to do more in their line of security work. And there is an academy that provides all of this training. Also located in one of our highest need zip codes, which is, I guess, sort of just coincidental, but they train those individuals who are going to be patrolling parking lots, hotels, those types of places where people can be found overdosed, in a hotel room or in a parking lot, parked in a car or in an alley, behind a building. And this partnership has led to at least 7 lives saved that we know of. So again, when we first started doing that, to my knowledge, no other large-scale Narcan distribution programs were exploring that type of partnership. And since then, we've also done training with other security firms and connected with other security firms so that their staff could get trained as well. But probably critical awareness has been the most lucrative in terms of, through that we've been able to reach nearly 600 people who are now working or were currently working in the security field. Just a little bit of a breakdown of the trainings that we've provided. Drug Free Duval, our main training and outreach partner, has reached nearly 2,000 people in the community with the Narcan training through over 100 trainings. And they have been also extremely nimble in how they have approached training. So of course, in the beginning, we were focused on in-person outreach and in-person training. And we always kind of talked about maybe trying to have a virtual component. And then COVID made that a necessity. So we transitioned to virtual pretty quickly. And about half of their trainings are virtual. A lot of people still prefer the in-person training, and we're happy to provide that. Some places want to do a hybrid where some individuals can participate remotely and some can participate in person. We've been able to accommodate that. So we've really been able to meet whatever the needs of the organization is or the group is as far as making sure everybody gets access to the training. And then they mail the Narcan kit so that it's, about as low barrier as possible. As I mentioned, Critical Awareness Security has also been doing the training as well. They've done 60 trainings. We started partnering with them in October of last year. And since then, they've reached over 500 individuals currently working or planning to work in the security field. And this picture here was a training I was definitely particularly proud of. We were able to train city council and their aides, as well as other city hall employees back in February of this year. And that really has, I think, helped a lot of city leaders, sort of understand some of the nuances of the opioid crisis and go beyond just, some of the base level understanding and really embrace and understand harm reduction strategies, especially Narcan access and distribution. And this just depicts some of the outcomes that we're seeing with the training. We measure individuals' level of perceived knowledge related to Narcan in general, as well as the Good Samaritan law, the standing order for Narcan, an individual's self-perceived confidence that they could recognize the signs and symptoms of an overdose and that they could properly administer Narcan if needed. And as you can see, we do see significant differences in the post-test compared to the pre-test on that scale of 1 to 5. The training has also been successful in addressing the stigma related to Narcan use and Narcan availability, because even though we've been doing this now for a few years, I would say still one of the most common questions we get or common pushbacks we get is, well, isn't this just encouraging drug use or enabling? And just with this hour-long training, we go from more than 1 in 10 participants believing that Narcan access does encourage drug use to, in the post-test, this decreases to less than 2% of individuals reporting this. And of course, what's addressed in the training that hopefully contributes to this is all of the peer-reviewed literature that shows that Narcan simply does not encourage drug use. What comes to mind for me, there have been a number of studies, but one that comes to mind for me was a very interesting qualitative study that came out last year. And some of the quotes were just very powerful. They were individuals who had presented in the emergency room with a diagnosed opioid use disorder, and they were asked to share their experiences and perceptions related to Narcan. And they overwhelmingly said, nobody chooses to do heroin just because Narcan's available. They're going to do it one way or another. So, and they viewed having Narcan available as very positive, but also admitted that they were reluctant until the very, very last second to even use it, which again goes against that common misconception that Narcan encourages drug use. Because in reality, an individual who uses drugs does not want to administer Narcan and does not want to be administered Narcan unless they have absolutely no choice. So they would wait until, for example, seeing that the person that they were with that was using drugs had blue skin before they would administer Narcan. And the reason being is because it gives, precipitated withdrawal or acute withdrawal symptoms. So it's very unpleasant. And the majority of participants also referenced that. And so Drug-Free Duval and Critical Awareness touch on these things in their training, which clearly is having an impact on people having a better understanding for why Narcan does not encourage drug use and how the use of drugs is just much more complex than that. So with this type of large scale distribution, we don't, and not wanting to introduce any kind of barriers to people feeling comfortable receiving a Narcan kit, we don't collect identifiable information or follow up, contact information to follow up with people. And to be honest, we don't really have the manpower to systematically follow up with over 5,000 individuals anyway. However, we did try to put, some mechanisms in place to encourage people to anonymously report if they do end up using their kit to save a life. And one of those things was an anonymous survey on SurveyMonkey that someone can go to a simple link and fill out some questions and report that they use their kit that they received from the project anonymously. And through this and through other, types of reporting measures, we have gotten reports that 36 individuals have used their Narcan kits to save a life. And we of course suspect that the actual number is much greater, but I mean, 36 lives, it's just, picture a room filled with 36 people that, are fathers, mothers, children, aunts, uncles, friends, it's just, clearly it works, clearly it saves lives. And in addition to that, I also look at another measure, which is the number of instances where a bystander uses a Narcan kit prior to JFRD's arrival on the scene of an overdose. And we have seen that since our project began, there's been a significant increase in this type of reporting. And that increase has consistently exceeded the increase in overdoses that we've seen, unfortunately, particularly in the midst of the pandemic. So
Laura, I'm sorry to interrupt you. Just wanted to let you know that in the comment in the chat box, it says, "So glad this is being addressed," from Jennifer. And
great.
Shelley is asking a technical question about the SurveyMonkey to report anonymous overdose reversal. Do you have the link to that?
Yeah, sure. If you want to just take a look, I'll put it in the chat right now. If you want to just take a look without submitting anything, you can definitely see what questions we ask.
Thank you very much.
Yeah, and I just put it in the chat. So feel free to look at it because it won't hurt just to look at it as long as you don't submit any information. Yeah, and let's see, do I have one on me? Yes. Just since you guys asked, this is what the label looks like. It's very bright because I want people to notice it. And it has a QR code as well as a link. So anybody who has a smartphone could also easily access it by using the QR code. And then the link is also on there. And it just says, if you use this Narcan, report anonymously at this link. And once you submit, you'll receive instructions on requesting a free replacement kit. Of course, mind you, I never wanted this to be conditional. So people can get a replacement kit, just by asking. So any of the partnerships that we work with, I like to hear these reports because it definitely helps, as a reminder that this is working, and it's really encouraging for everybody who works so hard to get the Narcan in people's hands. I love getting the reports because it really helps for, again, showing that this is working. However, again, I never wanted it to be conditional. So really, truly, any distributing partner knows that if someone says, "Hey, I need another kit," they're going to give it to them, just for what it's worth, because I really don't want to be the Narcan police or Narcan gatekeeping or anything like that. And in addition, we do track, the inventory and everything and all the kits that are given out. And we try to encourage folks to take a survey if they receive a kit that just collects some additional information, demographic information, things like that. But that is optional. So the vast majority of people are perfectly happy to fill it out. But I've had partners reach out and say, "Hey, but what if someone wants a kit for their friend or, someone that needs it?" I say, please give it to them. Again, we're not the police. As long as we have the supply, if someone says that they need another kit, give them another kit, because data collection is great, but it should never be at the expense of people getting a resource that they need. And I also just wanted to talk about some of the outreach that we've done. Of course, this has been very difficult in the wake of COVID, and I imagine that things would have looked very differently had that not been a factor. But I am proud of some of the outreach work that we've done recently, and we're certainly not the first ones to do it. But just noticing the uptick in overdoses that are occurring in public spaces, and we just, me and some folks that work in harm reduction in the community decided we really need to do some outreach, especially with the bar community, restaurants, et cetera, especially in some of those high risk areas. So here's just a couple of news clippings showing, you know, people are doing this in Atlanta, Gainesville, other communities, and we decided to try it out as well. So we called it a Narcan bar crawl, even though we of course targeted different kinds of businesses. It was just a little clever way to kind of get our volunteers excited about the idea. And of course, no alcohol was consumed while we were doing it either. Planning and preparation, we just mapped out the area. It's an area with a high concentration of bars and restaurants in what's called the Riverside of Jacksonville. I created a spreadsheet with the information that we needed, addresses, phone numbers, just in case, points of contact if we had it. Some information like whether it was a 21 and up place, because some of our volunteers were under the age of 21, and we wanted to ensure that you know, they weren't going to get kicked out, you know, as we were trying to do this outreach. Materials we had, of course, in our Narcan kits, but also demo devices like what's pictured there. Those devices have been really, really helpful in being able to provide that quick training and show people how easy it is to administer Narcan. We had quick start guides and other literature, our forms, you know, because we wanted to track our efforts and make notes and things, get follow-up information from owners and managers, and also business cards so that people could reach out to us. The messaging that we decided on, we wanted to keep it simple because we wanted this to be a quick thing. We didn't want to walk into a restaurant and say, hey, do you have an hour? We wanted to say, hey, do you have 5 minutes? So the messaging we stuck with was overdoses are on the rise, especially in public spaces. And this is backed up by our data. Alcohol combined with opioids, of course, increases the risk of overdose. And this was particularly important, you know, when discussing this at restaurants and bars and breweries and such. Of course, some businesses might be concerned about liability, so we had quick messaging related to the Good Samaritan law. And another common question is, well, what if I'm mistaken? What if someone's not overdosing on opioids? I give them Narcan. Have I hurt them? Am I going to get in trouble for it? And we, you know, one of the messaging points was that it does not affect someone if they don't have opioids in their system. So it's always better to just go ahead and administer it. In the case of an emergency, call 911 and they'll get the help that they need either way. And I couldn't have done this alone. I was fortunate enough to connect with a local harm reduction mutual aid group that had been meeting regularly. It's sort of a all are welcome type of group, you know, regardless of whether you're currently using substances or not, or you're in recovery, just people who just really want to make a difference and really want to address this, especially on the street level. So it was a group of easily 10 of us. Some of the outcomes, we were able to engage with 22 businesses ranging from bars and restaurants, a barcade, a movie theater, tobacco vape slash vape shop, gas station, and more. Of those 22, only 4 weren't interested in Narcan, and critically, only 2 of those was because they already had Narcan and they knew how to use it. So really, the interest in receiving the training was widespread, which I don't know if that would have been the case a couple of years ago when we first started. I think that that's really been kind of a quick shift in people's perspectives about Narcan. And so we were able to provide the training on the spot to 9 businesses. Another 9 asked for follow-up. And some of the businesses that we provided the training to on the spot also asked about follow-up for other staff. We gave out 22 kits to businesses and staff. And another critical thing is that doesn't include the street outreach. So I would encourage anyone who's considering this type of outreach effort to also not ignore the fact that you're possibly going to interact with folks on the street who could use this information as well. And again, about not being a gatekeeper, not being, you know, not separating out things. If you interact with someone who is interested in learning, just give them the training on the spot, just like you would anybody else. If you can get them to fill out, you know, any kind of data collection that you have, that's great too. So we did have some folks, volunteers with us, who specifically said, you know, you guys do the businesses, the bars, we'll handle the street outreach. And I thought that that was really great. Yes.
Laura, we have another comment in the chat.
Sure.
Pam says that she has met the recruiting and training manager for daily convenience stores in Jacksonville. And she's interested in Narcan, and she put her contact, Pam put her contact information in the chat for you.
Fantastic.
Just to let you know about that one.
Yes, I would love to pursue that. In fact, the gas station that we interacted with was not a daily gas station, but it was a Shell gas station, which I know that they're like connected in some way. It tends to always be at Shell stations. And in that case, actually, the employee was really interested in the information, but she informed us, of another challenge with engaging with businesses, especially smaller businesses, which was that she said that a lot of times there's only going to be one employee at the gas station. And, so she just kind of felt like she wouldn't be able to respond in any capacity other than calling 911. She also provided some other insights into what's going on in the community. She said, to her knowledge, she had never seen someone who she suspected was overdosed on an opioid, but she said that the alcohol consumption in the area, particularly with individuals who might be homeless or something like that, that it had gotten really, it had escalated, especially in the midst of the pandemic. And this was something that we knew and we suspected coming from other data sources, but it was definitely confirmation of that coming from that individual. So I will definitely jot down your number, Pam, and also please be sure to grab my email at the end. So in the interest of time, because I do want to address any other questions folks have, I'm going to skip to talking about the SSP in Duval County, the Safe Syringe Program. There is an academic model that we've been kind of looking at in relation to this, and we have effectively kind of moved in here in Duval County from the exploration phase to the preparation phase with this process. Brief timeline. Of course, there are folks who have been talking about this for decades, including in Duval County, but where things really have started to pick up momentum was just about a little less than a year ago, where the topic was brought up at a city council special committee meeting, and a harm reduction subcommittee was proposed right at that meeting, which I have to admit, even I was surprised at how quickly everything kind of happened. But we got permission to have a harm reduction subcommittee on that, which was really critical. We had a first planning meeting where we gathered stakeholders, and we planned for, speaking with a council member who was on that special committee meeting who had agreed to sort of head the subcommittee. So we had a stakeholder meeting when we planned on that. And then just a few days later, we had the meeting with the council member. And I will tell you, after that meeting, I didn't think we had gotten through to him, especially in terms of a syringe exchange program. But evidently he marinated in the information, because a couple of weeks later, he reached out and was like, what are the next steps? So I think we were all a little bit surprised by that. But very, very pleased also to see the progress. The harm reduction subcommittee was incorporated as a regular agenda item, which was great because it always gave us the opportunity to connect with Councilmember Boylan regularly so that he would be prepared to provide those updates at the special committee meetings. I didn't put every single meeting that we had with stakeholders on here because that would have been a very long conversation and presentation on its own. But I did want to highlight that pretty early on, we wanted to engage with law enforcement. This was something that other communities admitted after the fact that they should have done sooner. So we kind of said, as a harm reduction group, okay, let's open that Pandora's box. And it actually has been very positive. I think that they've been happy to be part of the dialogue. And it's really opened up a lot of conversations that I think a lot of people are kind of surprised are happening, which is really fantastic to see in real time. We had a bunch of people, yes, in the middle of a pandemic, but all wearing masks, come to a special committee meeting in May to really show there is a diverse group of stakeholders that want to see this happen. And I think that surprised some of the council members who were there. I think our champion, Councilmember Boylan, was pleased to be able to say, look, this is not a fringe idea. This is something that the CDC is endorsing. This is something that the current administration, the White House, is supporting, and we need to not be left behind. We had another stakeholder meeting in May 2021 where we expanded even more as far as who we were engaging in the conversation. And we had just a few days ago our first publicly noticed meeting to introduce the legislation, the ordinance that could make a legal syringe exchange program in Duval County a reality. And the meeting went very well. I'm running low on time, so I don't know if I'll be able to go into all the details, but I think it went very well in terms of at least one council member there in attendance who had previously not seemed to be supportive at all, starting to really see the value in it and listen to the speakers and listen to the evidence. And he started asking questions that were more, how is this going to look? Like, what will this program look like? What are the requirements of a program, instead of, we don't need this program. His questions were very practical in nature. This is a list of the stakeholder groups we've engaged with thus far. We've got representatives from prevention, recovery, and everything in between. We've engaged with the state attorney's office. And then most importantly, the organizations that are working with these target populations already, and could refer to this type of program or could even operate it in the future. And some things that we took into consideration here in Jacksonville, because every community is going to be a little bit unique with this conversation, is that we are a consolidated city-county. So other communities are working with their county commissions. We're working with our city council instead. Adaptations with respect to language, our council member champion, CM Boylan, recommended early on. He said he liked the idea of a safe syringe program rather than a syringe exchange program or even syringe service program. So we took that language and we ran with it. And I personally think that it's a fantastic, adaptation of the language. And it's true. A sterile syringe is a safe syringe. And he also really emphasized that we need to demonstrate our readiness to implement. He did not want to pass an ordinance and have it sit there in the books for a year before a program got started. He said, there's clearly a need for this program, and the need has been there for a long time. So if we pass this ordinance, who is going to step up and get it going quickly? So we've been, working with a lot of community organizations that might be ready to implement within 3 to 6 months. And local legislation with regards to service procurement, we've had the ability to do this because there are specific rules normally for procurement of services with the city, but because this is related to services related to substance use and or mental health, there's exceptions to that, to the normal procurement rules. And so that has helped us to already have a lot of conversations with organizations that could potentially start this program early and not have to worry about violating any kind of procurement law or anything like that. And another reason why I don't think those laws would apply is because you're not allowed to use local funds anyway. So on 2 levels, we didn't have to worry about that. This is our key messaging. Just all the evidence as to why this is really needed in Duval County related to our high rates of HIV infection, hepatitis C infection, the astronomical costs associated with treating these things versus preventing it, as well as hospital injection related infections, things like endocarditis, MRSA even, and the overdose deaths. So I can't help but think to myself, I can't believe I've been directing a Narcan distribution program all these years when really who I need to be connecting with are the people who inject drugs. And it is just so difficult because they have been stigmatized and sometimes, so therefore they're not going to be the ones to show up at a treatment center, even to get free Narcan. And I'm very mindful of that. So I would love for this program to be a reality, if for no other reason than to be able to give Narcan to the people who need it most in the most effective way. So we focus on the needs and we focus on the evidence, the research that shows that a syringe exchange program or a safe syringe program can decrease transmission of HIV and Hep C, reduce syringe sharing behaviors. That was found in the Miami program. Decrease the number of syringes discarded in public spaces, decrease overdose deaths by getting Narcan in people's hands, and link people to substance use treatment and resources. People who inject drugs who engage in these types of programs are 5 times more likely to get connected to treatment versus those who don't. And it makes sense because it can be that linkage to care that they need. It might start with the syringe, but it can really lead to something much more valuable. And we did get some media coverage from the publicly noticed meeting. This article, I think, was a little bit better written and it had a lot of positive comments on the social media side. This article, you can already see some, not person first language. So I wasn't thrilled about that. We actually did engage with a couple of groups to see about, how can we connect with media to talk about stigmatizing language and using person first language, when reporting on these topics. But anyway, there's another article, and there was a lot of comments from the public on this article, but not all of them were good. But it was a good opportunity to see what are the common things that are coming up that we need to be able to address in the future. So one of the most common things was, well, that's fine, but what about people with diabetes? What about people, who need EpiPens? Why are we providing syringes, but not, for those people? And of course, we were able to say, we had a little group of people who were in the comment section, really politely, not being antagonistic, really politely saying, well, actually, someone with diabetes would be able to use this program. The article didn't, and then people were concerned about taxpayer money. Well, the article didn't mention this, but actually local funds would not be used for this. It would be private donations and other really grants. So we were definitely able to get a picture of what are going to be some of the naysayer comments, especially from the general public. And the good news was that a lot of them were just simply, not true, as far as no, someone with diabetes or MS or, who is using needles for hormone therapy, they could get free needles, and that might be really important to someone on a fixed income. So even though I didn't love the article, it was still a valuable learning exercise. And the last thing I just wanted to say is, I look at this chart a lot, and of course it needs to be updated because sadly 2020 numbers go up even more. And I just wanted to say one last thing, really bringing it back to harm reduction, and please, listen to people in harm reduction. They have a perspective that other people in other fields don't, because they could have seen this third wave coming, or they did see it coming from a mile away, because policies were put in place that only addressed supply. It didn't address demand. And harm reduction folks could have told you, well, that's going to lead to an increase in people who were previously using prescription drugs to go into the illicit market. And that's where they're going to get their drugs. And we're going to see an increase in heroin deaths. And I don't know if they had the hindsight to see that leading to the fentanyl crisis that we're in now. But again, they certainly did see the wave 2 coming. So all this to say, some of the things that got this crisis going in the first place, we're just now talking about now. There's a movie coming out on Hulu called Dope Sick. The events of that movie took place in the 90s and the early 2000s. We're in 2021 now. And I just don't want it to be another 20 years from now before we're really willing to say, hey, talking about policies in a vacuum, only focusing on the supply side and not the demand side, not listening to harm reduction folks. I don't want to be talking about in 20 years how we should have been doing those things now. Yeah. So I know we're right at 12:20, but if anybody has questions in the chat, maybe Lynn could make sure I get them via email, or I don't know if we have a minute or two.
Yeah, we will follow up with you if we have questions in the chat. We'll definitely get them to you. Thank you so much, Laura. You really compacted a lot of information into this short amount of time that you had here. We do really appreciate it. And for all of the participants, we appreciate your attendance as well. And please look in the chat for a link to the session evaluation for this session. And also the link to the program where you can find the plenary session. That will be starting at 12:40. So if you're interested in joining us today for discussions about adverse childhood experiences, we would be happy to have you then. So take a look there. And I think that's all we have. All these sessions are being recorded, so they'll be available to Summit participants later. So please reach out to us if you want to contact Laura. And we really appreciate everything you've said for us today, Laura. Thank you.
Thanks so much for having me. I really appreciated the time.
Thank you. I'm going to close this meeting now and hope to see you all in the plenary session.
Great.